Hey, everybody. Thanks for joining in for this uh, MASLD MASH Community Network discussion. My name is Erin Tanner. I work for GastroHealth in Birmingham, Alabama, and I've been doing general gastroenterology for 14 years. Today, we're going to talk about MASLD, which is metabolic-associated steatotic liver disease, as well as MetALD, which is kind of a new nomenclature coming around, and that stands for metabolic associated liver disease, as well as alcoholic liver disease. We'll start with a case study. Ashley's a 52-year-old female. She's been referred to the GI clinic for having an abdominal ultrasound that showed mild hepatomegaly and increased hepatic echogenicity consistent with steatosis. She has no complaints. She feels well. As you can see over here to the left, her BMI is 29.4. Ashley's past medical history includes PCOS, hypertension, hyperlipidemia. On physical exam, she has a smooth liver edge, nothing significant on her physical exam. As far as her medications go, she takes amlodipine, atorvastatin, multivitamin, as well as milk thistle, and she drinks on average 2 glasses of wine per day. Here are her vital signs and her labs. As far as her vital signs go, her blood pressure is a little bit elevated, 140/78. Her BMI is 29.4, so she is considered obese. As far as her labs go, pretty unremarkable here, maybe a mildly elevated total bilirubin. Hemoglobin A1C is borderline for prediabetes, and then she does have a mildly elevated triglyceride level. So in the GI clinic, we ordered a FibroScan for Ashley. As far as her FibroScan results, she was found to have significant fibrosis, suggesting F3 fibrosis, with her KPA score at 11.4, and then her CAP score was 310, which is consistent with severe steatosis. So when we think about steatotic liver disease, we need to kind of break down with our patients, is this all fatty liver or metabolic associated, or is there alcohol related? Is it a combination of both, or is there another etiology for the steatosis and the fibrosis of the liver? So if you can see in the middle here, you can have patients that have metabolic associated liver disease. And then if you look at their weekly alcohol intake or their average daily alcohol intake, these are the averages here. And you can have patients that have metabolic dysfunction contributing to their fatty liver that also have increased amount of alcohol intake. And these are the patients that we would characterize as having MetALD or metabolic liver disease with alcoholic liver disease as well. And if you look over to the right, you want to always be sure to rule out other causes for liver disease. Wilson's disease, autoimmune hepatitis, PBC, things like that when you have patients that appear to have a chronic liver disease. This slide just describes the different alcohol intake that patients have and how many grams of or the percent of alcohol in each of these types of beverages. So, if you have a patient that drinks 3 beers a day, that's 5% alcohol in each beer. And as you move over to the right, the hard liquor has much more higher percentages of alcohol intake. And this should be considered when we're trying to decide, is alcohol really contributing to their steatosis or the fibrosis of the liver? So as far as the etiologies here on the left, you can have patients that have metabolic factors such as insulin resistance, diabetes, obesity. And then if you add alcohol intake into it, this is what happens in the liver. You have impaired lipid handling, which increases fat in the liver. And then you have oxidative and endoplasmic reticulum stress. This leads to cell death, and then which impairs cell signaling. And this is what increases the fibrosis of the liver. So you can have these metabolic dysfunctions. If you add alcohol intake on top of that, this is going to accelerate the progression of liver disease and certainly increase their risk of developing fibrosis at a higher rate than just with patients that have metabolic liver disease. This table just describes the risk of decompensation. You can see here the level of fibrosis scores. You have F1 to F4 there. And then if you have metabolic-associated steatotic liver disease, if you look here to the left of this chart, and then if you add alcohol into it, certainly the risk of decompensation increases over a 5-year span. So it's very important to try to decipher, does your patient only have metabolic associated liver disease, or is alcohol playing a role? Because with these patients, we may choose a different route as far as their treatment goes and follow up. So there are different ways that we can check for the amount of alcohol intake. Certainly asking patients, how much do you drink? How many drinks a day? How many days a week? These are all things we can ask. And these are very subjective reports from our patients. But going forward, I think there are going to be several objective ways that we can assess the alcohol intake in our patients. In this box in the middle here, you can see there are some blood tests. There's even hair sampling you can do to assess for the amount of alcohol consumption. And in further slides, we'll go into more detail about which test we should try to use. So this just describes how we should kind of assess our patients. So you have a patient with steatotic liver disease. Certainly we want to assess for any metabolic dysfunctions, diabetes, high cholesterol, obesity. And then we want to ask about their alcohol intake. Certainly if a patient says, yes, I drink alcohol, how much do you drink? And some patients may not disclose how much they drink. They might not realize how much they drink. They think, oh, I just drink 2 glasses a day, but how big are their glasses? So there are certain biomarkers we can check, such as the PEth test. This is a laboratory test that is very specific in assessing for how much alcohol a patient is consuming. And then in the middle here, you can see alcohol use greater than 350 grams a week in women and greater than 420 grams per week in men, and their PEth test levels here. This is how you would differentiate a patient that had just MASLD versus MetALD. Again, you always want to exclude other sources for liver disease before you treat a patient for MASLD or MetALD. This is just showing that having isolated hypertension or hypertriglyceridemia, that's certainly having only those metabolic risk factors can increase your risk for MASLD. Again, here's your PEth test. This is very specific test. It's a simple blood test that can help us decide how much the patient is actually consuming in alcohol. So for our patient Ashley, her PEth test came back 120, which is consistent with moderate to heavy alcohol consumption. Again, she had her BMI was elevated, her triglycerides were elevated. She had a borderline A1C. As far as the PEth test goes, It is detectable for 3 to 12 days after one single binge drink. There's a mean half-life of 3 days. The table to the right just shows that there's no significant variability in the gender of our patients or how big they are or their BMI. This was a study done using the PEth test with patients who had excessive weight. This is just describing there is not much variability in it. It's okay to use the PEth test no matter how much your patient weighs. Again, gender also did not show a significant variability in the results of a PEth test. You want to exclude patients that have other liver disease etiologies. Even if they do drink alcohol, you always want to be sure they don't have any type of autoimmune liver disease or viral hepatitis. So for Ashley, she had PCOS, hypertension, hyperlipidemia, and her PEth test was 120. So with her, we would say that she does have MetALD as the source of her liver disease. This is just describing how alcohol, initially, when you drink alcohol, it can decrease your systolic blood pressure anywhere from 0 to 12 hours. And then after that, it increases your systolic blood pressure, as well as the heart rate. It increases your heart rate when you drink alcohol. So this can certainly contribute to more cardiology complications when you drink alcohol. As far as triglyceride levels, patients in this study were given water or alcohol, and you can see that their triglyceride levels, even if they already had high triglyceride levels, did increase after the consumption of alcohol. So the risk of cardiovascular comorbidities when drinking alcohol and having MetALD is significant. So again, Ashley, she's 52, she's overweight, she has metabolic risk factors, hypertension, hyperlipidemia, borderline diabetes. She had fibrosis on her elastography, and also her PEth score was high. So we would diagnose her with MetALD. So what are the current treatments? Certainly recommending Mediterranean diet, weight loss, exercise. Right now, resmetirom is not used in patients that drink alcohol, but maybe in the future it will be. But that may be something to consider. Certainly avoiding all alcohol in patients such as Ashley is highly recommended. And then she was found to have F3 fibrosis. So certainly she would need every 6-month HCC screening. So things to consider here when thinking about clinical trials for MetALD. It's hard to just have a patient say, sure, I drink alcohol and I have fatty liver, but making these criteria objective is going to make the studies more accurate. So using the PEth test to quantify or make objective how much your patient drinks is beneficial. We want to be sure, like in the previous slides, we saw how patients' blood pressures and heart rates increased with alcohol consumption, as well as the triglyceride levels. So when considering a patient to have MetALD versus MASLD, you want to be sure that they actually have hypertension or hypertriglyceridemia. So you would certainly encourage your patients to completely abstain from alcohol and then determine at their baseline, do they really have hypertension or hyperlipidemia? Also, other risk factors, exposures you want to document these things for 6 to 12 months before determining if they're really MetALD or if they just have MASLD. Again, take home considerations here. Alcohol intake beyond 140 to 350 grams per week for women, or 210 to 420 grams per week for men. That's considered to be MetALD. Consider the biomarkers. There are lots of labs out there. Hair testing, PEth is a simple blood test that you can order in your clinic to determine the amount of alcohol consumption. Reassess metabolic dysfunction over time. Do these patients really have hyperlipidemia, or was it strictly related to alcohol? Also consider that when you talk to them about hypertension. You want to exclude all other liver disease etiologies. And then, when considering patients for clinical research, you want to have this objective data, not just a subjective, yes, I drink 2 alcohol beverages a day. So basically, use the PEth test. And that's all for this program. Please let me know if you have any questions.